I think I need to be quiet. Okay, so now we're on. You can click, thank you. And you can click OK, uh, because it's going to ask you that again.
Okay.
Okay,
I don't see it. It did not ask me, so
so
it
you're good. You're
yeah,
good.
so I'm good. Yes.
So great. Welcome, welcome, welcome to Medical Mondays with Dr. O. Um, this is an exciting episode, like all of our episodes. This, though, is one that is not done. I don't think this has ever been done anywhere. What we're going to do here today, except in medical settings, and definitely not at the level that is going to be done tonight. I am Toyin Okwesami. I'm a family practitioner in Maryland and hostess of Medical Mondays with Dr. O. Tonight, I have my sister that who I fondly call rather Daisy. She's Dr. Arvinder Uppal, who is the founder, chief executive officer, radiologist, patient advocate, teacher, and leader at Charter Radiology in Maryland. It's the best radiology facility we have. She's also the best that we have. And so we are blessed in Maryland, but you don't have to be a Marylander to benefit from her. And we'll talk more about that later. Dr. Opal opened Charter Radiology in 2014, building the practice from the ground up so that there will be no compromise in quality. That is the fact. And she's the only woman I know, maybe in the world, that has built a standalone, her own radiology practice. She received a medical degree from Albany Medical College and completed the radiology fellowship at the Johns Hopkins Hospital. During her medical training, she was the recipient of two prestigious research awards and has authored numerous articles and presentations on advancements in radiology. She has a reputation for meticulousness in her interpretations and is highly regarded by referring physicians and patients alike as a doctor who values and delivers the most personalized care. That is not
Mr. Tekoja, how are you?
that is the
Good
truth.
evening. Are you available now? Are you picking up children?
Dr. Maduka, kindly mute. Thank you. Dr. Upal's commitment to quality shows in Charter Radiology's array of state-of-the-art imaging technology, including three Tesla wide bore scanners, which are the gold standard in imaging. She has also assembled a team of highly trained radiologists and technologists to complement her own radiologic expertise, offering an unparalleled patient experience. In addition, Dr. Opal has been consistently recognized as a top doctor by Baltimore Magazine because of her commitment to radiologic experience and compassionate care. You will not believe that she 100% gives compassionate care. This is care that you will see in like primary care settings, pediatric and clinics and all. She does that in radiology setting. I have personal experience and we'll talk more about that later. Without much ado, Dr. Upal, who bear with me, all through the night, I may alternate between Dr. Upal and Daisy because that's that's my sister, and that's what I call her. I'm yielding the floor to you. Please take over and welcome. Thank
Thank
you.
you. Thank you for such a warm welcome. I could have not said it better. So I have been always very passionate about breast MRI, and I have been doing breast MRI since I was an MRI radiologist. I have been doing breast MRI for the last since 2000. So it's 24 years. I'm fellowship trained in breast MRI, and when I opened Charter Radiology, I wanted to build the best program. So how do you build the best program? You buy the very best equipment. We were the first outpatient facility to buy Siemens MRI 3 Tesla. So we bought the first 3 Tesla, and then I went and I purchased the best breast coil, and I will show you. So the breast coil is the camera that closes close to the breast, and it images the breast. And we chose the Sentinel coil, which is the gold standard in breast MRI. And we will talk about all of that, how I accumulated all the components. So I want to start by first talking about what are the indications for breast MRI. So the women who have a higher than average risk for breast cancer, for example, patients with strong family history, women who are BRCA1 and BRCA2 mutations, they must undergo an annual breast MRI. Families that have syndrome, Lynch syndrome, actually predisposes you to breast carcinoma. I have several families who have Lynch syndrome, and all the sisters in that family all have breast cancer. Very sad, but these families must be screened very closely, not just with mammography, but with breast MRI. Lee-Fraumeni syndrome is another syndrome that has a very high disposition of breast cancer. Any woman with a calculated risk of 20% or more must undergo an annual breast MRI. Patients who already have a personal history, who have breast cancer, undergo lumpectomy, and subsequently every year as a follow-up must have a breast MRI in addition to a mammogram. As I already said, patients with strong family history of breast cancer must undergo breast MRI. So there are several genetic mutations that predispose women to breast cancer. Since I do screening mammography for breast cancer, I have quite a collection of all these patients. Ataxia telangiectasia mutation, the ATM mutation, predisposes women to get breast cancer. They have a higher than general population risk of getting breast cancer, at least double the risk. Women with the C7271T to G mutation, they have at least a 50% chance of developing breast cancer over their lifetime. And again, like I said, I have quite a few collection of these. Women with Cowden syndrome are predisposed to getting breast cancer. Women who have had a prior biopsy, and I wanted to put in this case, but I think in the next talk, when I come back, I will show you patients with atypical ductal hyperplasia and lobular carcinoma. They are also predisposed to getting a higher risk of breast cancer. Women with, BRCA mutations we talked about, they definitely are predisposed to a higher risk for breast cancer. And then anyone who has had prior chest radiation for lymphoma, women with prior radiation who for lymphoma are also increased risk for breast cancer, must undergo an annual breast MRI. So these are some of the factors of who are the women who are going to be developing breast cancer. We all know that by now: first degree relative, Ashkenazi heritage, dense breasts, prior biopsy for a high risk lesion, hormone replacement, personal history of breast cancer, early menarche or late menopause. These are all risk factors for getting breast cancer. So I wanted to really go over this, that, most of us see our OBGYNs calculating a breast cancer risk. So and I just got this slide, I just Googled it, because any woman who has an increased risk greater than 20%, I actually calculated my own risk. My risk came out to be less than 1%. So this is a pretty valuable tool. Women who go to OBGYN, their OBGYNs calculate their risk of breast cancer. And I was fortunate that I do not have a family history of breast cancer. So my risk comes back pretty slow, but highly recommend that people use this tool. So I really want to talk about how is a breast MRI performed, because most women who come to me for the first time really do not know how a breast MRI is performed. And I really encourage anyone who lives in Maryland, please come and see Charter Radiology. And most of you women should come and get a breast MRI. And especially if you're a referring physician, you should know, because when the patients come here, they really have no idea how a breast MRI is performed. It takes me a lot of time and effort to actually educate, and I spend the last 25 years I have dedicated to educating not just the patients, but also educating referring physicians. I think that is something that I'm very passionate about, is teaching referring physicians so they can become much better physicians, and they can explain to their patients how a procedure is going to be performed before they arrive here. Because when patients, and especially women, come here, they're very anxious. They have no idea what to expect. So I hope that this talk will educate some people today, and then we will keep on educating more people so it becomes easier. So I see that and the old time requisition, I would see that people would say, do an MRI of the unilateral breast. So breast MRI is performed simultaneously of both breasts. If you're a high quality imaging center like us, you're going to do both images. Both breasts are imaged at the same time. I'm sorry if I point to my own breasts, but I do that a lot in talks. So both breasts are imaged at the same time. So we will acquire axial non-fat sat images. Then we acquire T1 fat sat images. We obtain them prior to and then giving contrast over 8 minutes. So very dynamic contrast enhanced images are obtained in 8 minutes. And because we have the highest quality machines and they are very fast, our breast MRI examination only takes 15 minutes. I'm sure that comes as a great shock to most people, because if you go to some of our other competitions and where the MRI machine is a 1.5 Tesla, or it'll be much longer. So it's always shocking to most patients to find out that their exam is over in 15 minutes, about the same time that it takes to get a mammogram. Since all of us as women have had a mammogram. So how is a breast MRI performed? So this is our 3 Tesla MRI. You can see how gorgeous it is. The sky is lit up. One of the big advantages is that
Are you changing slides, because we have only that first slide on?
Oh, this is I just changed the slide. Can you see this one?
No, we still have that first slide from the beginning.
Oh, yes, I am. I've been changing slides.
I figured that, and I wanted to say that the way you're talking, showing.
Yes, I'm
So
changing
click
slides.
next.
Oh, should I hit next? Oh, I could
Yeah,
do that. Yes.
yeah.
Okay, got it. Okay, now do you see it?
No, it's still the same slide. Yeah, go ahead. Somebody wanted to say something.
Oh, no, this is important. I need you to see this guides.
Yeah. So,
hmm.
Dr. and Dr. Ajay, This is her screen. What does she need to click?
Okay, so yeah, I need you to see these slides.
Mhm. So this is your screen. I'm thinking those three dots, can you click on it? And if it says something like
Share?
maybe next, maybe show slide, there's a
It
name
says
for it.
slideshow.
Slideshow. Slideshow. Do
Yes.
slideshow.
Okay. And I said
This is
slideshow.
a snipping tool, not a power. What does that mean? Somebody is saying this is a snipping tool, not a PowerPoint. Oh, okay. Can you please unmute and please guide her to what to do? Please. I don't know what a snipping tool is.
Is this it? Can you see it now?
No. We're still seeing that first slide.
Hmm.
Kindly help me, T. Kindly unmute and assist us in this. Let me see.
Can you hear me?
Okay, now, good. You're muted. Can you tell her what to do, please?
All right, so you have your snipping tool on, so you really have to, I don't know, maybe you were trying to copy this picture and put it in your PowerPoint. Are you trying to present a PowerPoint slide deck? If
So
not,
if
you're not
this
in
is
it.
a PowerPoint, now
No,
I
you
can
are,
see all of you.
no, if your
It's a
folder where
PowerPoint.
It's a
PowerPoint,
PowerPoint presentation.
unless you're in Google Docs, but if it is PowerPoint, if you can
Yes.
just go, yes, if you can actually hit your file, folder, your PowerPoint slides in itself, you can start from the beginning, so you can restart it, yeah. Seems like you copied that picture and posted it and you probably just left it on.
And she came in earlier. We thought we got it when she got the first slide in. So we're like, great, you have the first slide. You just have to click next.
Okay. This, so you still see this first one, right? That's it?
No, we're not seeing
Okay.
anything anymore now.
Now you're not seeing
Thank
any.
you.
The first thing you
Good
click
e-
on the share button, share.
Yeah, I was gonna say it looks like she's no longer sharing the screen.
Yes, somehow it took me off the sharing. I think when you
Okay,
were clicking,
go back to share.
should if I go back to,
Share.
Share my screen.
okay, got it. Here. Can you see it now?
You're not sharing
Not
anything
yet. We're not seeing. Okay, now you've started share. Fantastic. This is where you want to be.
Okay, so is it showing now?
Yes, we have your slides now.
Okay, so is it showing the next one? When I click it?
We don't know where you want to be.
Okay,
Go to
so now
slideshow.
I'm at indications for breast MRI. Do you see it?
Yes, we see it. Yeah.
Wow, lovely. Okay, and
Yeah.
then this was the next one for indications for breast MRI.
Yes, we see that.
You see the factors that contribute towards the risk?
Yes, but you went past it. Have you talked about that already? I don't think you have.
Yes, I did. I talked
Yes,
about how you
did.
calculate the risk calculator.
You did. You did the risk calculator. Yeah.
Yes, okay.
You see
This
it.
is
Yeah.
wonderful. Now we're right here. This is it. This is the slide. Do you
Okay,
see the
thank you.
MRI
Yes.
machine?
Yes.
Lovely.
Yeah.
This is beautiful. Okay, so this is the best MRI machine in the USA. It's a humbling, I mean, I don't like to say it that way, but this is really the highest gradient magnet, and this is a 3 Tesla MRI. Not only is this aesthetically pleasing, you can see how the bore is bright, right? You see that? The bore is lit inside, so people are not claustrophobic. Now, this is the breast coil that's placed on top of the table. Do you appreciate that?
Yes.
So the woman's head is outside the magnet. Do you see? This is where the head goes in, okay? And this is, so the woman is lying face down with each breast in these cups. So this is the coil, and each breast goes into these holder, and then the magnet, the table is slid in, the head comes right up till here. So the woman is not claustrophobic. The head is outside the MRI. This is a very important fact for most women like myself who undergo breast MRI. And this is a very comfortable position, even though it's not comfortable to be lying down on your stomach. So this is how the woman is lying. So it's feet first, it's face down, you're lying prone on your stomach, the head comes up to the bore of the magnet, arms are by the head, and the exam only takes 15 minutes with 15 minutes to position. Any questions on that?
No, we leave questions till the end.
Okay, okay. So I also wanted to show that, yes, we got the best machine, we got the best breast coil, but the whole program, we wanted to use the best contrast agent, okay? And I wanted to show, we chose to use Gatavist. Gatavist is the only contrast agent that is approved for breast cancer utilization. It is a very highly sensitive, also twice as expensive as other contrast agents, other gadolinium agents, but at Charter, we value quality, so we chose Gatavist. I also wanted to show you, this is from the brochure of Bayer, the company that makes this contrast agent, that this contrast is so safe in clinical trials, and I have been using Gatavist for 10 years. I can tell you that, touch wood, we have never had any reaction. Most of the reaction is if the patient eats before the exam and they might throw up a little bit. And headache, mild headache is the only complication. So this agent is really safe. So this is what a breast MRI examination looks like. This is a T1 that we say, this is as the breast parenchyma is when you scan a patient. There is no contrast. This is the equivalent of doing a mammogram. This is the glandular tissue. This is the right breast. This is the left breast. This is the heart over here. This is the rib cage. These are the nipples. So we do first a T1 sequence that is a non-fat suppressed sequence to just look at the overall appearance of the breast. And then we do a T2 weighted sequence where we suppress the fat. Do you see how the fat here is black and here the fat is white? Do you appreciate that?
Yes.
So this is the normal parenchyma. Why do we do a T2 weighted sequence? Because a T2 weighted sequence really helps an MRI radiologist to determine if there are cysts or fibroadenomas. So this sequence is very important. I promised you by the end of this talk, you're all going to become MRI radiologists who can read a breast MRI. So then we do a pre-contrast sequence, okay? And then we do a post-contrast sequence. Look at how clear the images are. Okay, this is a normal study. Now in the pre-contrast, there was no contrast in the heart. So when we give contrast in the heart, you can see that contrast went into the heart. That's how you know that this sequence worked. And then you look at this. So how I explain it is, if there is cancer, it will light up and become very bright. This is a normal breast MRI. There is no cancer in this breast. Any questions so far or at the end? Okay, so I really want to talk about this. A majority of the patients that I do, they have increased risk for breast cancer. This is a 68-year-old woman. She has a very strong family history of breast cancer. Her mother had breast cancer. Her maternal grandmother had breast cancer. Paternal grandmother had cancer. Maternal aunt, all with breast cancer. She had a mammogram that demonstrated asymmetrical density in the left breast. Her primary care physician was a very smart woman. She sent her for a breast MRI. This is her T1 sequence. This is just the one without contrast. This shows that actually her breast is not very dense. There is just minimal scattered granular tissue. This is her T2 sequence, and you can see there's nothing yet because the most important sequence is a contrast-enhanced sequence. Here is this lady with his pre-contrast images, and when I give her contrast, do you appreciate this white enhancing lesion in the left breast?
Wow.
This was biopsied, and this is invasive, moderately differentiated ductal carcinoma.
What does
I
invasive? Invasive means it's aggressive, right?
Yes, invasive is not the kind you want to have. So we saved this woman's life. She's 68 years old, by the way. She just underwent her bilateral mastectomy. This is one of my latest cases. So I
So she got
highly,
both breasts removed.
highly ACR, and I put in charter radiology, strongly recommend women with a very strong family history of breast cancer to undergo an annual breast MRI. Here's a 44-year-old female with dense breasts who has been having annual mammograms since the age of 40. Patient presented with a lump. She had a mammogram performed 1 month ago, which was negative. And
Meaning
her
it was normal, right?
yes. The ultrasound demonstrated a hypoechoic mass. We did a biopsy and it showed ductal carcinoma with lobular features. Patient came to us for staging of cancer. So this is
the
our
ductal, what is that? Ductal,
So this is ductal carcinoma. So that is the cancer that actually starts to arise within your ducts. I'm sorry, I should have had a slide in there to show you the various kinds of breast cancer. But a ductal carcinoma is one that begins in the ducts, which is the one that you look up for in mammograms, is the calcifications are a very good giveaway for ductal carcinoma. So she had ductal carcinoma. So this again is T1 and T2. You know that these are just screening sequences by now. The money sequence is the contrast enhanced image. So here is the slide that shows no contrast, right? There's no contrast in the heart. And here, you know, we gave contrast and look at the cancer. It lights up like a light bulb. I'm
Wow.
sure you all saw that movie, right? Where Bruce Willis says that there's a light for landing gear, right? This contrast is the landing torch for this cancer. It lights up the cancer.
Yeah.
So that is why contrast enhanced sequences are so important in breast MRI. This lady, this was a biopsy. We actually sent this lady to biopsy, and it was invasive ductal carcinoma with lobular features. That's considered not a very good type.
Usually we leave questions till the last, but because of the technicality of what we're talking about tonight, the medical lingos, I just wanted to mention that Dr. Shoguro, welcome. Dr. Shoguro is on here. I don't know, she's been on Medical Mondays. She's a breast surgeon at Johns Hopkins. She said, in addition to mammogram, MRI alone is not standard. Mammogram and annual MRI is standard of care for high-risk patients. And Abby from London wants to know what dense breast means. She said, does that mean somebody has large breast? Are they busty? Is it what dense breast means? What is dense breast?
So, Dr. Sagunru, welcome. Many of these cases that I'm showing actually are Dr. Sagunru has actually operated on those cases. I didn't want to point out because, try to keep HIPAA safe here. But yeah, some of these have been operated upon by Dr. Sagunru herself. So now I showed you, this is a dense breast. Do you see how much? This is a moderately dense breast. I have even seen worse than this, okay? Do you see how much glandular tissue this is? And so breast cancer hides. Now, this is the same woman who had that breast cancer. Without contrast, you cannot see that cancer. Do you appreciate that? Like, this is the same woman.
Yes.
And that when the breast is that dense, especially on mammogram, it's going to hide that cancer. It makes it very difficult to see. And in a breast MRI, it is impossible for cancer to hide because especially with the resolution and the quality of images that we do, you subtract out the glandular tissue. So the cancer is really, it is basically in your face. You cannot miss it. So this lady also had 2 additional lesions, and this is another reason for doing breast MRI is to not only diagnose the cancer, but to also look for additional lesions within that same breast and within that contralateral breast, because that is what determines the kind of surgery that the patient is going to have. And the breast surgeon that is the information that the breast surgeon is seeking, is if they are going to do a localized lumpectomy versus mastectomy.
So if they're going to do a lumpectomy, meaning removing the lump.
So if this was the only lesion that this patient had, the patient, and of course this conversation happens between the patient and the breast surgeon, where the patient may want just a lumpectomy to maintain her breast. But because this patient has multiple other lesions, this one and this in 2 different quadrants, this patient is no longer a candidate for lumpectomy. This is another case, pre-contrast images, and then this mass was a very lobulated mass, if you can appreciate it. It's multiseptated cystic mass, and you see the tail of this mass extending into the nipple. This patient actually presented with nipple discharge, and this is a very characteristic appearance of intraductal papilloma, which is a benign tumor, but is a precursor to ductal carcinoma in situ. So pathology, this is a pathology proven intraductal papilloma. So intraductal papillomas are benign lesions. They occur from the mammary duct. There is an increased risk of developing ductal carcinoma in situ and invasive ductal carcinoma. There are of 2 types, central or peripheral. This lesion that I showed you is the central intraductal papilloma. This is a large subareolar region, and patients usually present with spontaneous nipple discharge. I have several other small examples where they can be of very, very small size, and they usually just lie within the nipple. So they are just right here in the nipple, and they have nipple discharge. These patients present with nipple discharge. And usually the breast surgeons will go in and inject or do a ductogram, or we will put a clip in and the breast surgeons will remove these masses. This is a very interesting case. Actually, Dr. Sagundru was involved in this case. This is a 36-year-old woman. She actually underwent breast reduction, and she presented with a very painful left breast mass, with a very hard mass. We actually did an ultrasound on her first, and it was a very large mass. I convinced the woman to have a breast MRI, and this is her without contrast, and you can see that there is a mass here. And this is what it looks on the T2 weighted images. It's very bright and extends all the way down to her chest wall. This is her pectoralis muscle and extends all the way to the nipple. We gave it contrast, and this is again is pre-contrast images. This was the post-contrast images, and this mass lit up like a light bulb. The characteristics of this mass, although you could say this could be a breast cancer, but the way the morphology of this mass extending to the nipple with all that edema, we thought that this is a breast mass. It was treated conservatively first with antibiotics with no relief, and then the patient actually had surgical drainage. And she had to have a drain, and this mass was removed surgically. And it was a pretty significant abscess. Now, these cases that I'm going to start showing are pretty tough cases. This is a 47-year-old female. She actually presented with back pain. Her MRI was done somewhere else, and it showed metastatic lesion in her thoracic and lumbar spine. She underwent a bone biopsy, which showed metastatic breast cancer. She actually had a recent mammogram a few months ago. So we did her CT scan, and this is a CT of the liver. And I am not sure if you can appreciate these hypodense lesions in the liver. These are all metastatic disease. And if you look at her spine, she has these lytic lesions in her spine, and actually compression fracture of T10. These are her metastatic foci in her spine. Subsequently, we did do a breast MRI, and the breast MRI showed a mass in the left breast. This was biopsied, and this did show breast carcinoma. She also underwent a PET, which shows diffuse PET CT, which demonstrates diffuse disease within several bones. This patient has actually come back for a follow-up PET CT, and I wanted to show that she's actually in complete remission. 51-year-old female who presents with a palpable mass in the left breast, and the palpable mass was biopsied, and it's a biopsy-proven breast cancer. And so this information is very important to the oncologists, whether they are HER2/neu positive or not, and if they are estrogen receptor and progesterone receptor positive and Ki-67. These markers are very, very important to an oncologist, who then prescribes chemotherapy on how to treat these breast cancer. And so here is this lady. This was actually a really sad case. So as you can see, this is the one T1 weighted sequence, axial images, no contrast. And I think at this point, you have all become radiologists. You can appreciate these masses. There are multiple masses within the left breast. There are these 3 large masses. You can appreciate the skin thickening. And after contrast, you can see these large enhancing masses in the left breast. Actually, we did several scans on her, and her masses actually extend all the way down in her left lateral chest wall and extending down in her abdomen. This woman is actually as young as she is. It's a sad, 51-year-old, but she is actually doing well, and she will be coming back for repeat imaging. So hope to have more images on her. This is a 78-year-old female, and she presents with a palpable right breast mass. Ultrasound guided biopsy was done, and this is a biopsy-proven, poorly differentiated ductal carcinoma. So here is this mass. This is the T1 weighted sequence, and you can see that the right breast mass is so large that it's fungating outside of the right breast. So this whole thing is a tumor invading the nipple and pretty large mass.
Fungating means it's growing and, even outgrown the breast, like on the T2 image.
Absolutely. And it's very sad, these masses, sometimes when you examine them, or these women, you can see the mass fungating outside, and we as physicians, we talk about it. We talk about it during a conference, and I can tell you that so many of these women that I'm presenting today, they feel a palpable lump, and they do not tell anybody. They think it's just going to go away. And that is the tragedy. Even after we have such an outreach program of breast cancer, Komen Foundations, Johns Hopkins, MedStar, you name it, we all have huge outreach programs. I'm passionate about giving talks from charter. I try to educate patients. I can tell you every one of these women who presents with a palpable mass will hide it from her husband, from her family, and it is really sad. So I always say, why delay care? You could have been a month ahead. You could have been 2 months ahead. And I can tell you that there are several women who will hide it. I think I've been doing the breast conference at Howard County General since 2000, and every year, every week, every month, you will see these patients who present with these masses, who hide it from their provider or do not seek medical care. So here is that mass, pre-contrast and post-contrast, and oh yeah, this is another one. This is another very large mass, and you can see how big this mass is, and it has so many satellite lesions. Not only does it have over here, but there is a lesion even in the contralateral breast. It's another 53-year-old woman with a rapidly growing left breast mass. And so here is her right breast and no mass, and here is this large mass in the left breast. And you can see there's another satellite lesion over here. So after this is pre-contrast, and of course, when we give contrast, it lights up the mass. You can see the mass, and it's centrally necrotic, and there are satellite lesions just inferior to the large mass. And this was poorly differentiated ductal carcinoma. There's another 68-year-old woman with diagnosed with invasive ductal carcinoma of the left breast, and this is ER/PR. These receptors are very important for the oncologist to be treating these masses. So I did want to give you the pathology on it. So here it is, T1 weighted image, right breast is normal, and you can basically see on a non-contrast image, you can still see that there is some kind of a mass here, but without contrast, we cannot define it as well. You give contrast, it lights up like a light bulb, and then there is a satellite lesion in the left axilla over here. It's the same mass showing you the satellite lesions in the left axilla. Another mass, 68-year-old woman with biopsy-proven invasive ductal carcinoma with these markers. This is actually a very interesting mass. So here's T1, and you can see that you really couldn't see this mass. Now this is, Toyin, you asked me what is dense breast. This is a dense breast. Do you see how much parenchyma there is? A breast cancer will easily hide in these breasts. And here is the mass without contrast. With contrast, it lights up like a light bulb. And this has biopsy proven to be poorly differentiated ductal carcinoma. This is a 57-year-old woman with invasive mucinous carcinoma. And this is a T1. Again, this is actually a very, what we would say is moderate glandular pattern of breast parenchyma. There is still a lot of fatty replacement of the tissue. Here is this mass on the T2-weighted sequences. And when we give contrast, it lights up. Here, this is invasive lobular carcinoma is the hardest to diagnose, even on MRI. So this is a T1 weighted image, and this is a good thing. The reason I put this case in, I wanted to show, if you look at the right breast, it's a normal breast, but if you look at the left breast, you see, do you appreciate the nipple retraction and the skin thickening? That's what we refer to as pewdy orange. And here on the T2 weighted images, you can really appreciate the skin thickening, the nipple retraction. And when you give contrast, this mass is very necrotic, but it enhances on the rim of this mass.
Wow.
This is a 82-year-old woman with also invasive lobular carcinoma. And the reason, again, I put it is that this lady has breast implants, and I wanted you to appreciate how the right breast was smaller than the left breast, and I wanted you to appreciate the skin thickening and the nipple retraction and this mass arising from just the retroareolar region. And after contrast, it really lights up like a light bulb. This is another mass that you can barely see, but here is the mass on the non-contrast images. And when you give contrast, it shows this enhancing mass. This is a well-differentiated invasive ductal carcinoma. 53-year-old woman presents with rapidly growing mass in the left breast. The last mammogram was performed 6 years ago. And some of these cases, I put it to really emphasize that even with having such a massive outreach program, many of us still do not go in for their routine annual mammography. And so this is the reason why I have chosen these cases to emphasize some of this pathology. So here is this lady with pre-contrast images. T1 right breast is normal, but you can appreciate this very large mass. It's actually invading her left pectoralis muscle, and there is a satellite lesion. I don't even have to describe it, right? An image says 1,000 words. Skin thickening, you can appreciate the skin thickening, nipple retraction, and there is this large mass which is enhancing, many satellite lesions. And that was invasive ductal carcinoma.
But she didn't have mammogram for 6 years.
I can tell you that, so
MRI for 6 years.
Dr. Sugandru and I will tell you that, yes, we cannot emphasize, we almost have to be police for each other to tell our patients and advocate for our patients, our friends. I think when people see these images, I think the importance of screening mammography and screening breast MRI becomes very important. Here is another mass. This is, again, these pre-contrasts, and if you look at it again, there's skin thickening, there is retraction, nipple retraction. The right breast is smaller than the left breast. This was actually inflammatory breast cancer. So this is classic findings for inflammatory breast cancer, where we have skin thickening, we have that what do they say, pewdy orange appearance, so that it looks like the orange peel, and there is an enhancing mass. The entire breast enhances. She also has enhancing lymph nodes, and this was inflammatory breast cancer. This is another example of inflammatory breast cancer. 66-year-old man, Toyin asked me if I had placed any men with breast, and I wanted to emphasize this. Men also get breast cancer, but men frequently get gynecomastia, and also men are also shy about coming to a provider to discuss their breast mass. So if you look at this, this is a male breast, and you can almost appreciate how small this is compared to a woman's breast. You can see, so if you look here, this is the nipple, okay? And here is this mass in the retroareolar region. And this is on the T1 sequence, and this is on the T2 weighted sequence. And when we give contrast, oh, what did I do with it? Anyway, you have to take my word that this did not enhance, and this is classic for gynecomastia. This is a really nice case. I wanted to put an implant case. This is a 78-year-old woman. She has silicone breast implants, and her mammogram showed that her implant is not doing so well. So we do these sequences that are silicone suppressed and silicone enhanced. So this is her breast. This is the silicone implant. And you have to take my word for it that these are normal membranes that happen in the implant. This is not a intracapsular rupture, but this left implant is ruptured, and you can see that the implant wall is not intact, and actually the silicone is leaking outside of the implant and right here, and it's going to the left lateral chest wall. And here is, it's right along the left rib cage, and the silicone is leaking outside of the implant. Here is a sagittal view of the breast. You probably are more familiar with this view since this is like a mammogram view, and you can see how the implant is disrupted and the silicone is leaking outside the implant. This is the same patient, and I wanted to show you how dramatic it is. The silicone is leaking right along the chest wall. This is a 60-year-old woman with right axillary breast mass. I think this is one of Dr. Sugunru's patient. So I wanted you to see, first of all, you had asked the question, how do you tell that this is dense breast? I think this qualifies as a dense breast. Do you appreciate how much breast parenchyma there is? On a mammogram, it would be very easy to miss a mass in here. And here is the mass in the right axilla. On the T1, it's dark, bright on T2, and after we give contrast, it really lights up, and this was an invasive carcinoma. And you can tell that there is contrast. And I know it's hard for you guys to appreciate the high quality of our images because you have nothing to compare it to, but believe me that it doesn't quite get any better than this. So that was her biopsy. This is the reason I wanted to show you is another indication for doing breast MRI, which is the reason breast surgeons will, after they have even proven that it's a cancer, they will get a breast MRI, and it is performed for surgical planning to see if there is carcinoma in the same breast in other areas, and if there is carcinoma in the contralateral breast. So this was a woman, and you can all see this brightly enhancing cancer in the right breast, but she also has an enhancing lesion in the left breast, which changes her management. This is a MIPT image, and I really like these MIPT images, even though I don't really use them for diagnosis, but I love the way they look. Because they kind of show you how these vessels feed into this cancer. So it's very impressive. This is a case 20, invasive ductal carcinoma, moderately differentiated. This is a woman who had a prior history of breast cancer. So I basically tried to give you an example of every case that there is an indication for doing breast MRI. So this is a woman who's had prior history of breast cancer with prior lumpectomy. We strongly recommend that these women have an annual breast MRI even after undergoing lumpectomy. So she had a strong family history of breast cancer. Her mother had breast cancer, and we were asked to differentiate if she has a carcinoma. And the reason why I showed this is that breast MRI it is very easy to differentiate scar versus carcinoma. It is the easiest thing to diagnose on breast MRI. Scar will never enhance on breast MRI, and cancer will always enhance. So here is a woman. You can see that her right breast is smaller than her left breast. That's because she underwent a lumpectomy. Now, this is a spiculated mass, and that's what we call in radiology, where if we see this on mammogram, we are worried that this is cancer. So it is dark on T1, bright on T2. So we still cannot tell from here if this is cancer or not. And the minute we give contrast, we can see that this mass does not enhance. It does not become bright. And on subtraction images, you can see that this mass did not take up any contrast. It is with 100% confidence that I, as a radiologist, can say that this is a scar and is not a recurrent carcinoma. So 51-year-old female, she presented with a palpable lump. She too did not tell her family about it for a few months, couple of months. And then she came to us and we did an ultrasound. And this ultrasound clearly shows that it is very spiculated. It's shadowing. It does not look like a simple cyst. This is a very highly suspicious for breast cancer. We did a breast MRI. Now, this is not very dense breast because her glandular tissues are spread out. This is a non-contrast image, and even on this non-contrast image, you can appreciate that there is a mass here. This is T1 pre-contrast, T2 pre-contrast. You give contrast, and it lights up like a light bulb in the left breast. So this lady not only had this mass, she had these two satellite lesions. I hope you can appreciate it. If I make a video, and as we span, as radiologists, we span through the images from back to front, top to bottom. The video shows that all these lesions, but I have shown that there is this mass, and this lady has two satellite lesions. This lady underwent mastectomy, and she is doing very well. So I urge all the women listening, I urge all my patients, my friends, people think I'm very passionate about breast MRI, and I always tell them, and Dr. O knows that I highly recommend that we get an annual screening mammogram. Currently, I think we start screening at the age of 40 for women who have a very strong family history. We recommend that they get an annual breast MRI starting at the age of 20. I showed you the indications in the very beginning for women who have very strong family history. I don't want to go through my 93 slides again, but wish I could go all the way to the top really fast. But women who have a very strong family history, the first slide, the indications, highly recommend that they start screening at a very early age. I really want to bring that one up again because I know we had a little glitch in the system first. This indication, anyone with ataxia, telangiectasia, ATM mutation, I have a whole collection of these patients. Now, anyone with an ATM mutation, they are at increased risk for breast cancer as well as pancreatic cancer. They are at almost double the risk of a normal population, and we must start screening very early at the age of 20. Women with the C7271 ATM mutation have a much higher risk of developing breast cancer. I have several families who have this syndrome, Lee-Fromeni and the Lynch syndrome. They are at a very high risk. I have a family, sad to say, that all three sisters have breast cancer. And I also showed you how do you calculate your risk. The hard part is, so for some of us immigrant families, is that our mothers did not live that long or did not have access to screening. I know that I grew up in India and we did not even have a screening mammography program. So our history is not really known. Our family history of breast cancer is not really known. We are the first ones that are being established for breast cancer. I know that India did not even have, it still does not have a screening screening mammography program. There are very few institutions in India that even offer a mammogram. Vast majority do not even have a screening mammogram. So our history, it's hard to tell. When my providers ask me if I have a history of breast cancer in my family, it's hard to tell, right? I'm open for questions. I hope I didn't go too fast.
No, you did fantastic. Thank you so much. That was phenomenal. And I have to let everybody know that Dr. Uppal has been working on this since December to get these slides together. They are not easy. What she went through, the 93 slides she went through were not easy to put together. She spent Christmas Day doing this for Medical Mondays. So we really appreciate you. Thank you for taking the time. But somebody did ask about, the anatomy of the normal breast, which you showed in the beginning.
Yes,
She asked, so if you can
I
please,
can show that again.
yeah.
Um,
Dr. Shoguro, I'm going to call on you right after that.
So this is what the normal breast looks like. So we image a woman like I showed you in the axial plane. And we image both breasts simultaneously at the same time. So this is the fat, this is the axilla, this is the right breast. And by the way,
Axilla is the armpit.
yes,
Oh, yeah. So that's the armpit right there.
Excuse me.
Bless you.
Let me tell you, when I put this breast MRI program, and Dr. Sugundra missed it, and how in the beginning I went and got the breast. Of course, we got the 3 Tesla, and then I was passionate that we had to use the Sentinel coil. That is the best high resolution breast coil. GE and Siemens make their own breast coil, but they are not as high resolution as these images. So I don't want to be controversial, but the Sentinel coil was actually made by a private coil company. They were known for making exceptional coils for breast MRI. And we got this coil. So I actually went and learned how to position a woman in the coil, okay? And then I teach all my technologists how to position a breast. And when I first started Charter, I used to position every single woman. That's how crazy passionate I am. But now I have got good staff and they go tell me to be a radiologist, but I'm still very passionate. I got to go poke my head in there. I can't keep out of my, out of that lane. So see how this breast is positioned? This is how it's supposed to be done. There should be no tissue hanging outside over here. And we should cover, both axilla have to be covered on this image, okay? Because I don't like too much of chest wall because I want very high resolution images of the breast. So what is the anatomy? So the breast is predominantly fat, but I have showed you women with very dense breasts. The breast is made up of glandular parenchyma. What is glandular? This black area that you see, this is a glandular parenchyma, which is made up of ducts, lobules, and that is how mammary ducts, that they are the ones that they produce the milk. And then, of course, it gets discharged from the nipple, and this is the nipple. And this is your right breast. In between is the sternum. This is the sternum. This is the ribs. That's the heart. And then this is the left breast over here. Did I do a better job explaining this?
You did an excellent job. Thank you. You did before too, because I actually commented that you already showed the normal breast, but it's good. Thank you that you reverted back to it.
Yes. So this is very important in how the breast is positioned, because if you do not position the breast correctly, you will miss carcinoma. You will miss carcinoma in the axilla, and especially if the breast is
Under the armpit. The axilla is
armpit.
under the
Yes.
armpit. Yeah.
So you will miss breast cancer. So it is very important that you actually, so I teach my technologists how you must pull the breast forward into the camera, which is the, where the breast hangs. You must pull the tissue, and then you must have the breast pointing down. So that is how you accurately image it. Just like if you were taking a picture, right? You're taking a picture, you want the subject to be nicely positioned on your iPhone. And that's exactly very important for imaging, that the breast needs to be positioned correctly.
Thank you. So Dr. Shoguro, kindly unmute and ask your question or give your input. Thank you. And welcome.
Hi there.
I know it's your long day.
Yeah, no worries. No, Dr. Uppal, I wanted to say this was a great presentation. You gave such a textbook MRI presentation. I'm actually going to talk to you offline and invite you to maybe do a lecture for our breast fellow, for walking them through how to read breast MRIs, because even I learned a lot of things from your presentation tonight. So thank you. This was fantastic. So that's really what I just wanted to say. So I didn't have a specific question. I just wanted to tell you that this was put together so nicely in terms of the
I've been
imaging and
working on it.
diagnostic.
Yeah, my God, that's such, you have no idea how much I've been praising you, that you're God's gift to Howard County.
Yeah,
Um,
he's been telling me that. God's gift to Howard
you are,
County.
you are a God's gift to Howard County. The compassion, the expertise, the humbleness, I am at a loss of words that you are, oh, you were much needed in this county.
Thank you so much. And it's great to get to work with you.
So, but yes, I am very passionate about breast MRI, and it's great to have a great colleague to work with. It's a team effort, and we have a really great oncology team in Howard County. So I think we're very blessed. And yes, these images are spectacular, and it has to be done well. But I wanted to do breast MRI. So this is my round one. I promised Dr. O that I'm going to make it to be bigger than 50, and then we're going to put this on a webinar and make it available on the YouTube for everyone to actually view. And so I've been going through all the cases, and I really chose what I thought was a wide variety and cases that covered every indication for breast MRI.
Thank you. Thank you so much for that hard work. Thank you. Dr. Shoguro,
But Dr. Sugundra will tell you that
are
she
you
sees
there?
patients with masses, with women with masses who hide it for so long.
Dr. Shoguro? Yeah,
Yes, I'm here.
yeah. So your comment, okay, that was your comment.
Yeah, so basically I just wanted to tell her this was great.
Thank you. Thank you so much. So, Daisy, I need a favor because I've heard some text messages about where you are, your location. If you put that in the chat box, I can continue,
So we
rotating.
have 2 locations in Howard County, and both locations have a sentinel coil. And we are able to do breast MRI both in the Columbia location and in the Clarksville location. So Columbia was our first place that we used to do breast MRI. So a lot of the women are very loyal to that location because they've been going there. And then you cannot convince them to come to Clarksville no matter how hard you try. And then there are some women who will come to Clarksville for different reasons. So we have 2 locations in Howard County, and both locations have the breast MRI coil. Obviously, this scan that you're seeing, and you can see from the resolution of this image that this one is Clarksville because it is the highest strength magnet, and this is a 16-channel sentinel coil, whereas the one in Columbia is 8-channel. They're both spectacular. It's just a matter of, which patient likes which location, and we can offer it. And certain patients like a certain technologist, I don't have to tell you. So both choices are available, and we do not have a breast coil in Reisterstown. I did buy a breast coil for them, but unfortunately, more patients in Howard County support charter radiology. So we definitely have a breast coil for both centers here. So we're only doing it in Howard County. Yes.
Thank you for saying that because I'm one that is stuck in Columbia, even though I live in Clarksville. And
yes, I know.
It's walking distance from my house. I still will go to Columbia. So
that's why I didn't want to mention that patient is Toyin, who will only go to Columbia and will not come to Clarksville.
Yeah, that was me. So now that you said that they have the 16 coil in Clarksville, I will walk over there. It's walking distance from my house, and I'll switch going forward. It's just that Columbia was where we started, and it is what it is.
And it's a good thing because Toyin we sometimes say to patients that if you've had your prior breast MRI at Columbia, you should go there because it's easier for me to compare.
Well, that's why I normally go there. But you have 16 coil in Clarksville, so you'll have to move my record from Columbia to
Yeah, no, you can
That's what
come,
you have
you
to
can
do.
go anywhere. That's why I said it's whatever choice you like. It's up to patients. Yes. So both choices are available.
So, Dr. Ezugu, so if you put down the slides, you can stop sharing. I don't think anybody will need it again.
I will actually put this on YouTube and I will share this with
It's already on. It's
yes,
already on.
and then
As
you
we're
can share
speaking.
it with everybody.
As we're speaking is on, but stop sharing right now, so it'll be easier for me to see the hands up. Is why I was saying that. Dr. Ezugu, kindly
Scared to
unmute.
touch anything because I don't want
Just
anything to
stop
go
sharing.
wrong.
Go to
Dr.
sharing,
Uppal.
and you will
Yes,
see.
Yeah,
sir.
Dr. Uppal.
Yes, sir.
There you go.
Uppal, thank you so much for an excellent presentation and the details of that. And Dr. Shogula, thank you both for what you guys do for our ladies in everywhere. I have two questions, really. One is, having dealt with many of these ladies, what is the most common reason why they don't tell people when they have a lump in their breast? From what you guys have learned, so that we can know how we can address such situations. And secondly, you have really underscored the importance of breast MRI with contrast here. How is it easy with insurance and getting authorization approval for such a, yeah?
It's a challenge. So I wanted to tell this story when we first started that Dr. O, she's very humble. But when charter radiology first opened, getting contracts was virtually impossible for me because they wouldn't give me contracts since I was not a large company. And Dr. O actually fought for me. She wrote to payers for me to give me contract. She got me, which is now WellPoint. It used to be American. United Healthcare never gave us a contract, and Dr. O was pioneer. She fought and wrote letters to payers. Even after fighting for a long time, we never got United Healthcare. When we first got Aetna, I remember this, that they denied this woman a breast MRI. And that lady, so Aetna they said the patients could come something to charter, but they couldn't get their breast MRI. I remember this lady, she is a VIP at our center because she wrote to Aetna and she said, I will not go anywhere else for my breast MRI, but charter. She wrote to Aetna. So we call her that we have a contract with Aetna because of her. She brought down Aetna and Aetna opened up and gave us a contract because of that patient. So patient advocacy is very important. Patients are your biggest advocates. So very difficult. We know that patients with family history, they will pay, okay? Patients with ATM mutation, patient with BRCA1 carrier, patient with strong family history. So we are very careful. When I dictate, I put all that information. We ask patients for all that information. We ask referrers to put all that information in their EMR and in their clinical notes, because prior authorization is right now they're asking for prior authorization for everything. So those people, they will authorize, but that doesn't mean that they will authorize that they will pay, right? That's a whole separate battle again. But we have less trouble with these indications. They will pay for strong family. The indications that I gave you, they will pay for that.
So
we document it well. If the doctors document it well in their reports, in their clinical notes, and it's on the ordering physician's referral, and if the radiologist, we document it, they do pay.
Dr. Ezugu.
But you cannot use any person just wanting a screening mammography, they will not pay for that. Yeah.
So some of us want screening mammography, screening MRI. especially when that report came out, and the medical society became schizophrenic
Right.
about screening. There are, colleges like radiology, I think OBGYN that said that we should still be screening women starting age 40 with mammogram, but family medicine, internal medicine, and some other ones said no, we start at 50. Some say so because of exposure to radiation from mammogram. We also know that some of the mammogram machines, the newer ones, have lesser radiation,
Very low radiation.
very low radiation
Very
than
low
they had
radiation.
before. But
Yeah.
radiation itself to the chest is linked to breast cancer. It's why some schools are saying, no, you do the mammogram every other year and start later. Exposing your breast to
So
mammogram
yeah,
is a
1 in
problem.
8 women will get breast cancer from screening. But these
1
new
in 8.
machines keep coming and they keep lowering radiation dose.
Okay. So the radiation dose is lower in the newer mammogram machines, and they will let you know. Because my last mammogram, they actually told me, I didn't ask, that, this is a newer machine, it's less radiation and all of that. But I get MRI. I don't have family history, but after talking to Daisy, we just were having general conversation one day. This was years ago, and she talked about it, and I'm like, oh my gosh, I'm coming to get MRI. She says she does it too. I pay cash because my insurance will not pay, and my insurance is actually in United. So they won't pay. There's no reason. So I just go and pay cash. And a lot of my friends go to Daisy for screening and they pay cash. They even come from Nigeria to come do their MRI and pay cash. So it's your life.
I also wanted to tell you this, we should bring this up, that when you have a screening mammogram and you get breast tomosynthesis, you do get double the dose if you get, the breast tomosynthesis. But of course,
Can you explain that? Our audience don't know what that is.
so
Tomosynthesis.
it's the 3D mammogram that they try to convince you to get. So, but breast MRI, so there's a lot of other things to talk about that I don't want to talk about because I don't want to confuse the issue, because years ago they were talking about an abbreviated MRI, okay, to do that without contrast. Now, I am not a proponent of that. I mean, I showed you all these cases today, that how a contrast enhanced breast MRI really that is the most accurate way of diagnosing breast cancer. So I believe that you have to give contrast for breast cancer imaging, okay? And I also feel that on our MRI machine, it's so fast because it's such high resolution, and the exam is only, I've made the exam short so that it can be done within 15 minutes. Most of the women, when they come out, they're like, what? It's done? I didn't even finish listening to my song. So it's really fast, and I don't think you're lying in there for a very long time. 15 minutes is really fast, and I think most of us can tolerate that inconvenience. So those are my thoughts. I really think this is a life-saving modality.
Thank you. Thank you. Dr. Booker.
Sorry, what about my second question about why they don't tell? Why?
Yeah. Why don't women tell when they feel lumps in their breast? Sorry about that.
No, Dr. Sugundru spends more time. Maybe she can help answer this question.
She has her hand raised to talk, so we're going to ask her to answer that question. And there's another one for her in the chat box. Dr. Booker, kindly unmute.
Okay, thank you very much, Doctor. This was so informative. After not being as an anesthesiologist, I never really knew all this MRI was was present. But I wanted to ask one question. Have you ever done a lump in the axilla, which is cancerous, and not
Yes.
see a mass in the
Breast.
Yes.
breast?
Yes,
The
yes.
cases like that.
In fact, on our brochure, on the breast MRI brochure, that's a mass in the axilla. Yes.
Oh,
And there's no
Which
there's
is
no
which
mass
is
in the
why I
breast.
like to open up that field of view and cover the axilla, because that's very important that you must cover the axilla, because yes, breast masses occur in the axilla.
So
Yes.
the axilla again is the armpit, but
Mhm.
saying that there's no lump, you didn't see cancer in the breast, but then it's in
Oh,
the
he actually just did one of, it
Wow.
probably was Dr. Sagundra's patient.
Wow.
The patient presented, I thought I put that, but maybe I didn't. The patient had a mass in the axilla and was biopsied, and it was positive. Yes, I thought I was going to show that case. I'm sorry. And was biopsied, and that's how it turned out to be breast cancer. And then we subsequently did an MRI of the breast to see if there was tumor in the breast. Yes, that happens very often.
Was that tumor in the breast? No?
There was, I can't remember this case, but I have it. It's a very recent case that the lady had a mass in the armpit, and it was positive, and we subsequently did a breast MRI, and I can't remember if it was positive or not. I can't remember. I'm sorry.
Yeah, my sister-in-law has that. She had a mass in the
Yes.
axilla, but nothing in the
In the
breast.
breast.
And
Yes.
her mother had a history of pancreatic cancer, and I don't know what else. But I just wanted, because that wasn't mentioned.
So your sister had it?
My sister-in-law, my husband's
Sister-in-law.
sister.
Okay. Okay.
But I've seen it at work when I was working. Mass in the axilla, and the breast is, and those people are adamant about removing their breast. They just do axillary dissection. My thought about it as an anesthesiologist, as a doctor, I would take everything out, because I think there's a speck somewhere. And I've seen.
Can I just jump in? So
Sure.
that's called occult. I was gonna say that's called occult breast cancer.
Yeah.
And the evidence, there's no evidence that you must remove the breast. So you can either do the mastectomy. So you have to do the axillary lymph node dissection regardless, right? When you have the occult the occult breast cancer, then the evidence shows that there's no difference in overall survival between doing radiation to the breast or doing the mastectomy. So the thing is, even if you remove the breast, only in about 60% of cases will you actually find a primary tumor. So you may actually not even find a single cancer cell in the breast. So what we found is that the overall survival doesn't change if you do the axis section and you just radiate the breast. So in those cases, radiation of the breast alone without surgery is equivalent to mastectomy in terms of the overall outcomes just in that specific scenario, not in other cases, just the occult ones.
Thank you.
Fantastic. Thank you. So now is your turn. You had your hand raised before, and I have a question for you also from the.
Yeah. So the first question was about why women don't, I guess, say
They don't
things.
say. Let me
It's
tell you, let me
denial.
tell you this. Let me tell you this. I saw a patient not too long ago with fungating breast cancer. I have seen it in textbooks. I've seen something like Daisy just showed, like you see it in pictures. I had never seen one live. I mean, the whole breast is engulfed, and you have to see it. Well, you're a breast surgeon, you've seen it. I need to have seen it. But I saw it and I'm like, how? Will somebody keep this and not say anything? So that question is deep. Why would somebody feel a mass and think something is growing, you see it, and not bring it to attention?
So because patient, it's if you bring attention to it, then it's really there. Patients will live in denial because when they live in denial, they don't have to focus on the things that they have to focus to treat the mass. I have a patient that I operated on just today that has been diagnosed for over a year and kept on pushing it. First, she said she didn't believe the first surgeon and came to see me. And long story short is 6 months later, we get into the operating room. The mass is now 4 times the size, right? So I know that she's going to have a poor outcome. So patients, for things that are scary and are bad, they say, if I don't, out of sight, out of mind. I have patients who their own daughter had breast cancer and was getting active treatment for the breast cancer while the mom had a huge mass and didn't say anything to her daughter. A year later, this woman is in the hospital with respiratory issues. She knew she helped her daughter get through breast cancer. But in her mind, she said, if I don't say anything, then maybe it's not real. So once people have to accept that the mass is there, then they have to accept that there's something real and that they have to do something about it. So that's what I find, that if patients, it's out of sight, out of mind. If they don't say that they have a mass there, then they don't have to deal with it. There are 2 types of people. There are those that are simply out of sight, out of mind, right? And they don't want, they're in denial. Then there are those that are in denial due to a temporary hardship. For example, that one patient, the mother, she was helping take care of the daughter. Another time I've had women who were helping take care of their elderly parents, right? Who were maybe dying from other things and they were helping them with the house and this. So they knew they had a mass, but they couldn't stop and take care of it because then they wouldn't be able to take care of the other people that they had to take care of in their life. So there's 2 types. It's the denial because out of sight, out of mind. And then there's the temporary out of sight, out of mind because I have something that they perceive is so much bigger that they have to take care of. But what they don't realize is they don't take care of themselves. They cannot take care of that other person. So I've seen it both ways, in both situations.
Wow. Thank you.
And then I raised my hand to answer something. There was something.
There was something about cure for cancer by a man, by a guy in Russia who says there's cure for cancer on WhatsApp.
Oh, yeah, that. Yeah, no, that one
Yeah,
is
that's
not. We don't have any proven. I wish we did, that I wouldn't have to have patients die all the time, right? I cannot remember the second part of my question. So I think someone had said something and I was going to like answer it. And maybe it was the occult breast cancer part. I don't know. But anyways, if I remember, I'll let you know. But I just wanted to answer that denial question that oftentimes we see that. Oh, I remember. You were talking about radiation risk and the risk of,
from mammogram.
From mammogram and ultrasound. So just to Dr. Uppal's point, right? Just to bring that up, breast cancer is in 1 in 8 women. So that means you have a 12.5% lifetime risk of developing breast cancer. Your risk of developing a radiation-related cancer from the radiation exuded from mammograms or MRI. Ultrasound doesn't exude radiation. It's a different technology.
MRI does not exude radiation.
No radiation in MRI.
No radiation in MRI.
No significant, but I'm saying in terms of there are other risks in terms of like the contrast and things like that people will have associated. So any of the risks associated with MRI, mammogram, and those numbers are minuscule compared to the risk of getting breast cancer in your lifetime, right? So the risk of getting a cancer related to the radiation from a mammogram is way less than the risk of actually developing breast cancer in your lifetime. So the way I tell patients is it's a trade-off, right? So it's not it wouldn't be fair for us to say that there's zero risk associated with the imaging modalities. However, the risk of getting cancer is so much greater than the amount of radiation associated with the mammogram. The other thing too to keep in mind, and a lot of people don't realize this, is we all get a baseline amount of radiation just by living life, right? Depending on where you live, if you live in certain communities, certain more densely populated areas, the amount of radiation that you're getting just by living there every day is 10 times, it's like getting 10 mammograms a year. So just people don't, I think it's easy for us to, sometimes it's easy for people to say, oh no, I don't want to do this because of the radiation. And I get that all the time. The reason I say it is the patients will say that to me. So then I have to give them the numbers and the facts, right? And ask them where they live. And I was like, we can actually look up to see what the amount of background radiation that you're getting just by walking in and out of your house every day is. And it's way more than it is with the mammogram. So just when we want to stick to numbers, at the end of the day, there is a level of radiation toxicity associated with mammograms, sure. However, it is not as high as if the risk of getting breast cancer itself, the lifetime risk of an average patient, And it's not as high as a lot of certain areas that people will live in that are densely populated, have power plants, have bad, sewers and things like that. There's a lot of radiation and things like that just in those communities. So just to keep that in mind, that we all go through life and have a certain amount of radiation that we get through just by living life.
Dr. Uppal, go ahead. Thank you.
So, thank you. I have to say that in my limited experience of 25 years of doing radiology, 25 post fellowship, okay? So let's not even count the radiology. So I knew that I trained in Albany Med, and in Albany we had the Hudson River, and there were the PCBs, so they were the risk, and so that was one of my reasons for leaving Albany. I used to see so much breast cancer, and now look how much cancer. So I have never seen one case of breast cancer actually caused by mammography. So we are taught that, that, oh yeah, there is a low risk, but I have not yet seen a single case in 25 years of mammography induced breast cancer.
So where did they get this thing from that they
I
didn't?
don't know. It's something we're
Looked
just
at
taught
it
in the books.
and became.
And every year, these mammography machines keep getting better and better, and lower radiation and such lower. You actually get more radiation when you take a transcontinental flight to California, or even higher radiation, but people don't think about that, right? Because that's fun. We're flying to another country. But the radiation dose from this life-saving screening is, I cannot stress the importance of that. And I have said that other countries, yet, I know, of course, the developed countries have a great screening mammography program, but countries like India and Asia, there's those programs are very far in between. They're not accessible to everybody.
Well, thank you both for eye opener. It's good to know that despite what medicine is saying and our peers are saying regarding mammogram, but it's also important to note that MRI does not have radiation, and excuse me, ultrasound does not have radiation, because we need to know exactly what we are exposing, what we are getting exposed to, what we are doing. That's one of the purposes of this audience, and it's important to know that. So, Dr. Aluya, welcome. Kindly unmute.
Oh, yes. Thank you so much, Dr. O. And thank you for all that you do. I mean, to hear our good doctor, saying exactly what we know you to do, a medical advocate, standing in the gap for her, writing letters and all that. And that's what we need to truly do, to stand in the gap for one another. Because when it comes to healthcare and healthcare services, um, we need to be in the gap and stand for one another. Greetings from New Jersey. It's been a while. You can see I'm still at work, but I said I needed to join this because it's really important. It's really important because one way or the other, we are affected. As men, we're affected because we have children, we have mothers, sisters who are at risk for breast cancer. And as women, of course, the risk is really there. So, and I always say women are the custodians of our inheritance. So if we do not pay attention to women, then our inheritance is lost. And I thank you, Dr. O, for bringing our great doctor who's done a marvelous job showing us what we have, what is possible, and what we need to pursue so that we can save lives and livelihoods. Um, One of the reasons why we gather here almost every Monday, to do what we do is to, one, inform our community, to teach them some of the things that we know in the medical field, bring it onto the basic level so that people will understand. And not just understand, some of you will have heard me say, as an African adage, if you hear good news, you listen with both ears, but we're not just listening with both ears, but also acting on the information that you've heard, meaning telling your fellow brothers and sisters, this is what's going on, and teaching them how best to take care of themselves as well, and to also become advocates. Our doctor was saying one of the patients who they call VIP was the one who made sure that they got onto their insurance. Again, as patients, you can be advocates, and we've said that a number of times here. It's imperative that we begin to do that. Breast cancer, as you know, unfortunately, it's just so bewildering. And Dr. O, you were in our last Saturday event where we, brought a breast surgeon to talk about breast cancer at the doctor's lounge, because again, it's so important. And unfortunately, it discriminately affects some people more than it affects others. And we know the statistics when it comes to us. What, 2.3 million people every year gets, breast cancer, 400 and something die. In this country, about 342,000 die. And men get breast cancer too. 450 or 503, they say, die from breast cancer for men every year. So it affects us, and there are risk factors. But and the unfortunate thing is, for you and I, where we come from, people of color, breast cancer risk is increasing more for countries that are in transition. When they say in transition, meaning countries who are adapting to Western lifestyle. And unfortunately, a lot of us are beginning to adapt to Western lifestyle. One, the food that we eat characteristically affect everything, because the food you eat determines how your cell will repair itself. And the food you eat can determine how well those enzymes that repair cells, how functional that they are. And that's why it brings to mind when, the good doctor talked about, some of the genetic, what do you call it, gene mutations that predispose people to cancer. The leaf family, the ataxia telangiectasia, and all those things that they talked about. I mean, I've seen some where members of the family, from head to toe, all have cancer. In fact, one we're pursuing, one had the cancer of the eyelid, the other one the brain, and we consistently follow these patients. And especially leaf family, highly risk for breast cancer. Ataxia telangiectasia, the same thing as well. The question is, these two entities, the high penetrable gene mutation, also have affectation from the environment. We don't know what those mutations happen, but the environment has a huge hand to play with it. And unfortunately, we are where we are. Now, the question is, what do we do about it, especially in our community? One, inform and inform and inform. Two, stand in the gap, let people know what's happening and what we need to do. Now, my question to the doctor, two questions actually. One, could you take us through the steps, from the regular mammogram to the diagnostic mammogram? Because if you see somebody, abnormal mammogram, we see that all the time, and then the next stage and the next stage. What are the steps do people follow before they get to you, where eventually they need the what do you call it, the MRI of the brain, of the breast? Sorry, that's one. Two, with repeated MRI of the brain over series. I know, Dr. O, you said
Of the
you do
breast, MRI
of
of
the
the
breast.
breast.
Okay,
Yes,
I
of the
got it.
breast. I know you say you do MRI of the breast now.
Yeah.
What? Because you use
No risk.
gadolinium, which is
No
the
risk.
contrast
So
that
I'm
you
glad
use.
you brought that up.
No, wait, let him land. Let
Yes.
him land. Go
So
ahead.
the second question is, you use gadolinium for the MRI
Mhm.
that you do. Now, doing annual or serial MRI of the brain with gadolinium, we know what gadolinium
Of the
can
breast.
do to yes, of the brain, of the breast. Why do I keep saying breast? Of the brain.
It's okay.
We have to bring
Of
we
the
have to
breast.
bring the neurologist or
I know. Yeah, I know. I
neurosurgeon
do a lot of MS
over.
imaging too, so I know what
So,
he's talking about.
but to what is the effect of serial gadolinium exposure every year to that individual? And I'm sure there's some risk if you have to do that. So those are my two questions. And then, is it possible to do the same thing for MRI of the brain for MRI of the breast for men? Because again, they're still at risk.
Yeah, okay. So I'll take up one. So I'll tell you this. I remember this very vividly. It was in 1993, 4. I was a medical student at that time. I was at Albany Med, and the very first time I saw an South Indian woman with breast cancer. And, I had never seen an Asian woman with breast cancer, right? So it was very shocking to me. Subsequently, he brought up the point of the diet. We know that Japanese women, when they are in Japan, right? All these studies are well documented. I'm not making up any of this. You can Google it. There have been books written on it. So Japanese women, when they were in Japan, do not get breast cancer, or the incidence is very low. Okay, just like the incidence of heart disease is very low in Japan. But the minute they come over to United States and are exposed to the Western diet, their risk goes up. And same thing for me. I came to United States at a very early age of 19. So my risk and my diet is no longer what it was back home or back in India. And so my risk is now same as a risk of someone living in the United States because of the exposure to the Western diet. So my level is increased. So the good doctor asked a question on gadolinium safety. So first of all, we use Gadavist, which is very safe. And in my entire 30 years of career, I have never seen a case of NSF, which is nephrogenic induced fibrosis. Okay. I was the only one anal person, and Toyin knows how anal I am. We used to still check everybody's creatinine with iStat. I was the first one that instituted it at Charter, and we spent a lot of extra money. So I think just a couple of months ago, my technologist came to me and said, and Dr. Uppal, very respectfully, we never really disagree with you on anything or argue with you on anything for safety. But really now, even the American College of Radiology says this gadolinium is very safe, and nobody else, your competition, your academic institutions, all around in Maryland, do not check creatinine, because the one that we use is the safest, and they have stopped using. Can we stop checking their creatinine? And I said, okay, all right, we too will stop. But anytime that I think that any patient can be at risk, we will still check anybody who's diabetic or, so gadolinium is very, very safe. I have been doing a breast MRI on myself for the last at least 18 years, maybe plus. And I get a serial breast MRI every year. You can never say never, right? But really, this is safer than the water that we drink.
Dr.
This is how much I.
Yes. So the question is not on, of course, that's the,
There is
big.
there is no studies that have really shown that there is always a big question, and a lot of money people have invested in but no studies have really shown any harm of gadolinium.
Right.
It is really the safest agent made. CT contrast is, on the other hand, is a different story because it has iodine, it has definite implications, and we are very careful on how we screen for CT contrast. We are very vigilant on that. That's a very separate story. There are a few patients, I can literally count them on my 2 fingers, who are allergic to gadolinium contrast. And even that, I usually question their allergy, but I let it go because I don't want to argue with the patient. If someone tells me, it is extremely rare. In my entire career of 30 years, I can tell you that I can count less than 10 patients with gadolinium contrast allergy.
Hmm.
It is that
Well,
safe.
my referral to that actually was not with the respect
You
to.
are concerned about the amount of gadolinium. First of all, we use is so small. It's like
Mhm.
less than 6 cc's for most people of average size. And for me, I get 6 cc's of Gadavist when I have a breast MRI. And I can tell you that I have yet to see any complications of serial deposition of gadolinium.
Well, the question that, what I was bringing up was the new entity. I mean, things happen every day. People learn and know new things
Yes, yes.
as we move on, and that's the beauty of medicine.
Mhm.
It's on the issue of the neurocognitive effect of gadolinium in the brain. I mean, especially now with the fact that you're using more often. What do you call it? A couple of studies, especially one, says that not direct, but there are others that seem saying, hey, you know what? There's some deposits over time within the brain, and is this associated with some form of neurofibrillary tangles with Alzheimer's or whatever? The work is still out there,
No.
but we'll see.
So I just Googled while you were talking. So before there was a linear contrast, and macrocyclic. So these agents, now most of us are using macrocyclic gadolinium-based contrast agents, and these are so safe. I mean, you can Google it, NIH latest research. I mean, all these studies are all published in the national, that this is not a hindrance. You can Google it. It talks about macrocyclic, which is Gadavist, and how safe, their safety. All these papers are published in the National Institute, this National Institute of Health. These are all available on National Contrast. And it shows you, there's just so many studies. There are just so many studies. And it really shows the differences between each contrast enhanced there. In fact, this discussion has been going on since I was a med student. Even I actually wrote a paper and I submitted it for the safety of contrast agents. And contrast agents now are extremely safe. The macrocyclic agents, especially gadolinium, they're I would rather not have breast cancer than have any
Right.
the faint implication of anything added in.
I
So
totally agree.
and I tell you what, I shouldn't be promoting this, but mostly when they have to test any new protocol, guess who the guinea
Right.
pig is, who gets tested on.
True. True.
These are very safe agents, and in my career, and I work very long hours here. The twin knows, and I see a lot of patients, and I can tell you that these contrast agents are very safe now.
Right. Doc, I know they're safe. You see, one
Very
of the things
safe.
what I know they're safe, but one of the things that
What about
it's
all the other toxic agents that we drink every day?
no, well, that's where the issue is. If you combine one thing, it becomes a perfect storm. I'm not saying Gandalama is safe, no doubt. We've had over, I think some reports said over 450 million, worldwide has been used in the US, about
Yes, it's a
8.8
huge,
million. So,
it's the
right,
best
it's a
thing that
huge
ever
number.
was created. It's the person who
Right.
created it should get a Nobel Peace Prize or
I
Nobel.
totally agree. And guess what? I met a young man who's
Mhm.
working with NASA trying to do something else, a new contrast with MRI. So
Mhm.
in Florida.
It's
So
the
pretty interesting.
safest agent.
Yeah. But again, you see, the reason why I'm bringing
Truly
this
a
up,
Your
miracle
camera
for
is not on.
humanity.
I want to see your face.
it's no doubt it's safe, and I know it's truly safe. But what has been marching on lately that we never knew, that's changing the dynamics of every disease
Yeah, but this has
possible.
such an established track record. I, you can probably Google that worldwide, how many gadolinium doses are used per year.
I know the numbers. Doc, I'm not trying to say what you're doing is
Yeah,
wrong. I
I
totally
know.
agree.
It's a numbers
I
man.
can tell you that
Right.
my
So,
cost alone, and I'm a small imaging center, my cost alone for gadolinium, the amount of doses that even I use, I just in December, we were reordering contrast agents because um, um, I want to say this carefully because Toyin is recording it.
yeah.
Even a small imaging centers like mine, even the number of contrast doses that we use for gadolinium, and it is so safe. We've never touched
No,
wood.
but wait a minute. Now you have actually stopped using contrast, right? Because everything else has
We
stopped.
use contrast um for so many different parts of the body. We use it for brain, as he said, for MS. We use it for tumor imaging in the brain. We use it for in the brain. We use it in the neck. We use it in the chest, in the abdomen for tumor imaging. It is the most vital thing for humanity. That we use so much contrast and it is so safe.
Right. So this is where I come in,
So
and
I
I'll
don't
tell you
want I
why.
don't want us to confuse the audience because let
Right.
me
Yes, that's
we were
exactly that this kind of conversation
yeah,
is what does a lot of harm.
yeah.
And I try not to bring this up even in conversations
No, please wait
because
a minute. Let
people
me
say,
explain
oh my
this.
goodness, there is something that the radiology community is hiding. Radiology community is not hiding anything. It's you Google it and it's at your disposal.
Okay, let me
And
explain this.
look,
And
we're
let me
using it
say
on ourselves. We're using it on our family members.
let me see if you guys agree with this. We were at a meeting on Saturday with Dr. Aluya, but it's all doctors. And when we have doctor talk, we have to talk about the gazillion things that are not happening yet. Can
Yes,
they
because
happen?
patients get
Because
very confused.
one minute. We talk about things that, potentially can this happen? Because that's how we protect our patients.
Right.
That's how we protect ourselves and the public. We're protecting ourselves too, because we too are doing the same thing. I just said I go to Daisy to go do my MRIs and I do my mammogram at American Radiology. I do both. And the way it should be done. So we ask these questions. They're not questions for the general public because it gets confusing. Because these are things that we don't even know. We're just asking, is it possible that this could happen? Is this, what we're using now, should we pay attention? And that's where researchers start. Then somebody takes it
He
up
asked an
and then
important
research.
question. What should be the
So
process?
let me just say this and see if you and Dr. Aluya agrees with me, and so we can bring it back to layman's language. It is important for a woman starting age 40
Yes.
to get mammogram of their breasts. They need to do breast exams monthly. And they need to, by themselves, and then do their mammogram once a year. If there's a problem with the mammogram, the radiologist will refer them for an ultrasound, for MRI, for what have you that is needed. It's case by case basis that
Correct.
decide that. MRI has some radiation. The radiation, Dr. Shogoro has excellently articulated.
No,
Some
MRI has
people,
no radiation. MRI, no radiation.
sorry, mammogram, I said.
Mammogram has some
I
radiation.
said mammogram. I hope that was what I said. Mammogram. Mammogram has some radiation. The radiation from mammograms that we were using 10 years ago is totally different from today.
Yes.
Because of what we know, they've decreased and decreased and decreased the amount of radiation that a woman gets when they do their MRI. Not only that, Dr. Shogoro has excellently articulated to us that the chances of getting breast cancer from MRI is less, from mammogram, from getting cancer from mammogram is less in, than in some areas where people have exposure to more radiation naturally. So it is relatively very safe.
Very safe.
MRI has no radiation, zero, no radiation. But the question arose on Saturday about gadolinium. That should we start thinking about that is used in the contrast? Yes, we will research that, but there's not been any problems with it. That's that.
Very good.
Ultrasound has no radiation also, and those are important to know. Did I articulate that well?
Yes, absolutely. Very well said. These
Thank
are all tools. The whole point of this should be screening, because we know that right now cancer is, and people say, is cancer increasing? I say, no, I think it was always there. We are screening, so we are seeing more. But this is really life-saving modality. We should not be disagreeing on this. We should be channeling these women to screening, because it is very hard as it is, even though we have provided all these facilities, women are still not utilizing, women and men. So we should be encouraging and telling them this is safe. Go get this screening done. I think that should be the message from this talk.
I hope I articulated that well.
Yes.
Dr. Shoguro, please ask you, unmute. Thank you.
I just wanted to add to your last comment about radiation with mammograms. Just a friendly reminder, I see this all the time. Mammograms are safe in pregnant women, okay? The amount of radiation is not teratogenic to the fetus. And so basically,
Teratogenic means it will not cause cancer to the fetus.
right. So there's,
Maybe.
I think historically, there's been like this misconception where they say, oh, the woman's pregnant. No. She can't get mammogram. Wait till after pregnancy. I have had multiple patients who I've had to operate on while they're pregnant, but some of them, there are patients who also, while they were breastfeeding, their doctor told them, oh, it's fine. It's just from breastfeeding. And they ended up with stage 4 breast cancer. Okay. Yeah. So just a friendly reminder that the amount of radiation with mammograms is so low that it's safe for pregnant patients to get mammograms. So just a friendly reminder, a breast mass in a pregnant woman needs to be worked up just the same way as it is in every other woman. Never just say it's a simple breast mass related to breastfeeding or to pregnancy.
And by the way, I actually have a case which I didn't show this time. The woman was pregnant. She was 40-something year old. And I think she went to Dr. Segundo in the end. She ended up with her. She got a literally stage 4 mass during pregnancy.
Wow.
Yeah.
So what do you do during pregnancy?
What happens is
the
hormones feed the breast cancer, right? So
they grow more.
Mm-hmm.
So
but we should never discourage these women from getting worked up, because you cannot delay care.
Yeah, I agree. Dr. Aluya, go ahead.
Yes. So I'd asked 2 questions actually earlier on. I was not in doubt that gadolinium is safe, and I know it is, and we advocate that it should be done. And that's the message we need to put out there. But the other question was, and I had asked, Doc, to see what steps will there be before they get to you to do MRI.
So
You
like
understand?
I said, each case is individual based. So let's say you go for your screening mammogram, right? And they see a abnormality. So it depends upon if they see a mass. They usually take it to ultrasound, okay? And depends upon if they see anything on ultrasound or not. If they see a mass, they may recommend biopsy, or they may recommend additional imaging as MRI for problem solving. So I will get breast MRI in multiple different conditions, sometimes an abnormal mammogram, which does not come to resolution on ultrasound. The radiologist or even the primary care will intervene and bring in breast MRI for problem solving. And of course, if there is a mass, then, we take it to ultrasound, we biopsy it. And then if it is positive, then we take it to breast MRI for planning, for staging, for further characterization. So, those are all the reasons that I gave in the very beginning for indications. And any woman with all of those very strong family history of breast cancer, their doctors start ordering breast MRI starting at the age of 20. So they alternate. They will get a mammogram at 6 months, and then they will get a breast MRI at 6 months. This is called high-risk screening. These women are at very high risk for getting breast cancer, and they are very aggressively screened, both with mammography and breast MRI as a tool together.
Good. And they begin at age 20, right? You're
Age
saying?
20. For these
All
women,
right.
I have so many families that I showed you so many of those cases. Those there are sisters, and then their mother and their grandmother had cancer, so they get very aggressively screened by their GYN and their primary care starting at the age of 20. And if you
How
are
about for men? How about for men? What do
for
men
men,
do?
that's a problem. So if your father had, I have not Googled it, that if your father had breast cancer. So again, it runs in family. And so if you were a daughter whose father had breast cancer, then you would be the same way screened because of family history of breast cancer. You would be screened with breast MRI.
Right.
I wanted to ask that question. We tell women to do breast exams all the time, once a month, a week after their period.
How
So
many women are good about doing a breast self-exam?
I
I
am.
think women do a very poor job.
A lot of women are doing these days, I think.
Mhm.
Well, we tell them to. They said they are. We can only
Yep.
go by history. But what I was going to ask is this: what about men? I've never told a man to do breast exam. It just
Usually
occurs.
if they feel it, if they feel it, they see a size difference in their breast in the mirror, I think they talk to their provider. They're usually very quiet about it, and they will go and talk to their doctor, and then and of course if they have a good physician, they will send them for a screening.
No, they do. They
They
do.
send them
I've
for a
sent men
mammogram.
all the time because they tell me they feel lump. I don't even bother to examine. I just send them for imaging because there's no point. What if I miss it?
Yeah, but
I'm
a lot of them
saying
come straight to breast MRI. Yeah,
you missed my question.
yeah,
My
sorry.
question is, we don't tell men to do breast exams. I've
Yes,
never
no,
asked
awareness.
my men to do breast exam. Shouldn't we start telling men to also do breast exam? Dr. Shoguro? Yes.
So there are no standard screening
Yeah.
protocols for men, except for men who have a hereditary predisposition, right? Such as BRCA1, BRCA2, and other genetic mutations that increase their risk, number one. Number two is in those men, there are standard guidelines for them to start with screening mammography, right? Okay, if they have a BRCA1 and BRCA2 mutation, usually it's about age 50 for men, okay? Now, in terms of their in terms of monthly self-breast exams, in those patients, we do recommend that they do that. So in the high-risk male patients, okay, so genetic predisposition, the family history is not enough. So like, oh, my aunt or someone had breast cancer in a man is not as high when we calculate. It's higher when they actually have a genetic mutation for breast cancer. So in those patients, we start doing mammograms and we recommend that they do self-breast exams. In addition, in men with gynecomastia, okay? So that's the aberrant excess growth of breast tissue in men for gynecomastia. So males with gynecomastia, we do recommend doing breast exams. Why? Because they have breast tissue.
Yes.
concerned, you did the MRI on him. So we watched it for about 6 months, you know. He actually had a recent change in his medication, which is actually the most common cause of gynecomastia. Is usually it's usually iatrogenic. It's a medication induced change. And so I watched him for about 6 months after I had his cardiologist change the medication that was, you know, that could cause this. And it didn't change much. So my thing is, if I reverse the thing that's causing it, the gynecomastia should hopefully get better. And if it doesn't get better, and the man is a certain age, this man was around 60 something, 70, I'm not going to watch it, because male breast cancer is so hard to predict and find, right? So Daisy, I ended up taking him to the OR maybe a couple months ago, and he had ADH, atypical ductal hyperplasia, which is basically a high risk lesion for breast cancer. So
I
this
actually was
man,
going to show one of your cases. I had one of your atypical ductal hyperplasia, which is a high risk. So
so this is a male.
So you saved his life.
So with it, so Daisy had sent him to me because she was really concerned about it. She had done his MRI. I watched it for a while because now I identified the thing that was causing the gynecomastia, right? She had biopsied him. She biopsied him. It came back gynecomastia. I said, okay, let's watch it for some time, right? We would try to reverse the thing causing it. But I watched it for 6 to 7 months and it didn't change much. So at the 6-month visit, I said to him, I said, sir, my concern is that given your age, right? And he had maybe a remote history. It wasn't a significant, maybe like a great aunt or something like that with breast cancer, not a first degree relative. I ended up operating on him a couple months ago, and he had atypical ductal hyperplasia. If you leave that high risk lesion in 5-10 years, it could become a DCIS or an invasive cancer. So the point is, in men, so now that man, I have him come see us every 6 months. He is now officially considered a high risk patient. So because of that, I make him do monthly self-breast exams. He's going to get a mammogram every year, right? Because now he's technically high risk. So in the average male, we do not have screening recommendations, but in a male who is high risk, we do.
Thank you.
Right.
Yeah. But still not as a strong screening program like we have for women, though.
Wow. Thank you. Thank you for saying, both of you. Thank you, both of you, for your uneasiness on the man, Daisy, and for you, Tayo, for
No,
just
I told you that having
following
Dr.
him.
Tayo here is a blessing for Howard County.
Yeah, you keep telling me that. She says that a lot behind you. Tayo, that you're a blessing for Howard County. Every time she tells me that, I'm like, oh my God, she told me already.
And Dr. O, I think, we talked about this the last time as well, where we now begin to find out that, and in all sincerity, the question of BRCA1, BRCA2 usually don't come into doctors' heads when they're dealing with men. And most time we don't ask, hey, do you have a family member in your family who has breast cancer? We don't ask men those questions.
No,
But we
we
begin
don't.
to see we don't. And we begin to see now there's an increased risk that if you have a family member with breast cancer, especially BRCA or the HR2 new, there's an increased right. Right, HER2 new. There's an increased risk for men who also increases the risk for prostate cancer. And we don't talk about that. And that these are some of the things we begin to talk about as well. So that even for families where in the man there's a strong family history of prostate cancer, it also increases the risk of breast cancer in the females in the family. So that's the kind of discussion we must begin to start having, and especially in our community as well. So vice versa, breast cancer and prostate cancer, there's a causal relationship now, as we see. And we did talk about big risk, especially for those who come from Nigeria, northern Nigeria, big risk for that, those mutations that's taking place.
Daisy, Northern Nigeria, Dr. Leah was sharing, they come with fungating mass and they breastfeeding with the other breast.
Yes.
And, they have fungating mass. They walk into the clinic like nothing is happening.
I know.
So,
I've seen
it's a
so
big problem.
many. Actually, my staff asked me not to show those very, very scary masses today because they said they didn't want people to be very
Be
scared. So I still showed, I did show a few, but I did not, I have seen much worse. And my staff said that the whole point was not to scare the audience,
Yes.
but to encourage screening.
Screening, it's important.
It is
Screening, if
very
you don't take
important.
anything away from today's
Yes.
session,
Yeah,
screening.
so I did not show the very, very extremely bad masses.
And I have put in the chat box, Chatter Radiology, all the addresses, the phone number, and the text number. You can also text them. Kindly unmute Dr. Buka. I cannot believe that, you know, time has gone so much. When you're having fun.
Yes, I really enjoyed it. I just love your lecturers today, especially the surgeon. And your radiologist is so cute and so happy to give us things. But I just wanted to share one story about, I've seen fungating masks. They just don't look bad. They smell.
They smell bad.
Oh,
I didn't want to say that. You can smell it. You cannot stand in the room, or even in the center. Oh my, I know. I walk around. Yes, I did not want to bring up all these points.
Oh, you have to spray your mask in the OR. They stink.
Yes.
And they tell you outside, it stinks. Spray your mask before you come in. But I just wanted to share one story years ago about a male breast cancer. His wife, this is a couple, the wife was breastfeeding the son and he was a baby. And she said, oh, I just don't have enough milk for this kid. And the husband looked at her and said, oh, maybe he could come to me. I have some milk here. She was a nurse. And she said, what? And right away, she told him, this was in Guyana, to go to the hospital. He had breast cancer. Oh. And he's still alive, maybe 50 years later.
Wow.
So that was, he just jokingly said, oh, I have milk to give him. I just wanted to share that. This was such an interesting discussion.
Wow.
Thank you, Dr.
Thank you for sharing that, because, you know, you should not have discharge of any sort. You should not have breast milk if you are not pregnant or you're not breastfeeding. And if you have milky discharge, let it be evaluated. If you have bloody discharge,
abnormal. Yes.
If you have bloody discharge, let it be evaluated. If you have clear discharge, let it be evaluated. Don't be your own doctor, please. Any nipple discharge needs to be evaluated. It could be thyroid problem. It may not be cancer, but you need to get it evaluated to know what it is, and so it can be taken care of. It's better to prevent. We didn't even talk much about, you know, fat around the waist, you know, a lot of other things that could cause.
We just barely touched
this. Just wanted to encourage screening. Screen. When things are caught on time, we do fantastic. We've said that over and over on this forum. When it's done, when you find it later, it's a problem. And I would encourage you, most insurances will not pay for the MRI. Daisy at Chatter Radiology would do it. You can fly in from any state, pay your cash, and you get your MRI done. Call the office. I put the phone number on there, or you can text them. You can text them and dialogue. I have people who come from Nigeria. Daisy, am I lying? To come do their MRI with you. They come in, they my patients. We've talked about these screenings, and they will fly in to come do their MRI. So please take care of yourself. So before I revert back to you again, Daisy, for closing conversation, I saw here that Dr. Veronica, that's my sis here from California, posted this on the platform, and I don't want to ignore it. I will send it to everyone on Medical Mondays. Last week, we talked about it. One of our houses, my parents built it, caught on fire on December 22nd, 2024. And it's a huge place that is used to help people. People pay only 4,000 Naira a week there. 6 families lost everything, except the clothes that they have on their backs, including children. And the main building is intact, but it's not livable right now. But what we're focusing on is helping the people who lost everything and the rest of the people to relocate to get a place. They have to pay a year's rent. We want to be able to get them clothing and shoes. If you'd like to donate to that effect, please do. So this is what she posted here in the forum. And then I want to call on Mr. Oyemade. Mr. Oyemade, are you on the platform? So while Mr. Oyemade is unmuting, I want to say thank you to everyone who have donated to assist these families. I will send this link again out to our Medical Mondays family. If you'd like to donate to Global Vision Foundation. It's a non-profit 501c3 organization that will take care of these people, and it is tax deductible donation you'll be making. Mr. Makinde, are you there?
Mr. Oyemade, right? I'm here,
Mr. Oh my gosh, Mr. Oyemade. You know what? Your last name is so close to my last name. I can't mess up like that. I'm so sorry, Mr. Oyemade. Please go ahead and share with us what you plan on doing on Inauguration Day next Monday. And by the way, next Monday is Martin Luther King Day. We will not be having Medical Mondays. We have off. It's also Inauguration Day. We want to respect all of that happening in our community, so we won't have Medical Mondays. Next Monday, we'll return back the week after. And on that Monday, Mr. Oyemade, go ahead.
Yes, good evening, everybody. My name is Oluwaseun Oyemade, and I am the CEO and founder of Solution Prayer App, a platform that is designed to support spiritual growth and then bring people together like a global community of faith. And I'm also the founder of Cloud Solutions Tech, a tech company that is dedicated to creating innovations and solutions that empower individuals and communities. So with my Christian background, I came across, the inauguration stuff, and I feel that it's time for us, as a nation to pray together. So I would like to share the invite, for you guys to attend the presidential inauguration prayer. So this is not a political event. So this is an online event on January 20th noon, to bring everybody together in prayer. So that is exactly what we do at the Solution Prayer App. We have like a daily prayer. Is an app that is dedicated solely for prayer, Bible study, and a lot of features in it. And 2 Corinthians 7:14, it says, if my people who are called by my name will humble themselves and pray and seek my face and turn their wicked ways, then I will hear from heaven and I'll forgive their sins and I'll heal their land. So that verse is, kind of emphasizing the power of, collective prayer and faith, to seek God for our nation as we are going to be changing leadership. So I'm inviting everybody to join us for that prayer for the nation on that day. You can register to join this event on www.solutionprayer.org. We'll be happy, to have you in that for that event, so we can pray together for our nation. Thank you so much for your time. Thank you.
Thank you very much. I will share that link to register. I will send it by email, Medical Mondays family. I would also send it by WhatsApp. I resonated with what Mr. Oyemade proposed to do, because in Jeremiah 29:7, it instructs people to pray for the peace and prosperity of the city where they live.
Yeah.
The verse says you should pray for it, because if it prospers, if the country where you live prospers, you too will prosper.
Yeah.
So we need to take that seriously and pray for our nation. And by the grace of God, I will join in. Already registered. I will send it to you. Thank you so much for coming.
Yeah, thank you so much, ma.
Us.
Yeah, thank you, everybody.
Thank you.
Yeah.
Thank you so much for having me. I really, really appreciate this opportunity. And I cannot thank Toyin, who's a friend or sister who has stood by me when nobody else stood, and done so much for me.
Sounds like Dr. O.
Yes, Dr.
Thanks, sis.
Thank you. Thank you so much.
So, thank you for all you do for our communities. I remember patients that you will call me on Saturday. I send my patients on Saturday and Sunday. I'll say, hey, she would tell me, are you sitting or standing? Go and sit down because I have news for you. And she would tell me what I need to do because this patient has stage 4 cancer or something like that. So, Dr. Shoguro, before I revert back to Dr. Uppal, to Daisy, can you please put your information in the chat box, please? I have guests asking for your direct information, please.
Yes.
We are
Thank
Dr.
you.
Overtime.
So,
Yes.
Daisy, can you give us your parting words, please?
I mean, I'm a big advocate of screening. I'm a big advocate that imaging saves lives. And I believe in collaboration and working with great physicians together. I'm very blessed that I've been able to do that in my career. Most people collect diamonds. I collect great physicians to work with and collaborate. So that's my passion, and saving lives and has been very important to me. I think in some small way, I do make a contribution. I do think screening really saves lives in everything we do. Imaging saves lives because we pick up things really early. And so you can, if you see a problem, you can fix it. If you can't see it, then you really can't fix it. And we are very blessed that we live in Maryland. We really have some of the greatest physicians here. And it's really great to collaborate with so many great physicians.
Especially Dr. Shoguro, our blessing in Howard County.
Yes. She is. I still remember when Dr. Ewis called me and he said, Daisy, I'm done. I'm retired. I'm going to introduce you to Dr. Olu. That's what we call her. And you need to call her. This is her cell phone. From here on, she's your go-to person. I did. I called her the same day. And he said, I'm done. I'm retired. Now you need to call her.
We thank God. Thank God for her. She's been a blessing. Thank you so much, family. It's been an amazing night. And I hope that we all learned and take home the fact that we need to screen ourselves and be on top of our health. Breast cancer, especially, is number 2 leading cause of death, I think, after lung cancer. So this is not something to play with, and it spans everywhere, not just the United States, it's all over. So please screen, be on top of your health. And we are all here as resource for you. We're a family. And stay safe, be blessed. Join in the prayer on Monday. Let's do this together. Let's pray for our nation. Till we see again after Martin Luther King Monday.